the webinar. So in the very beginning, I would like to introduce good morning and good evenings all our friends in the ICC webinar. I am Dr. P.Y. Cho, and today my colleagues, Dr. Tin Chen Lu and Dr. Junior Tu, we all will moderate this webinar. And today our special speaker, the Professor Narayanan, is from India, and his topic is unilateral cleft lip rhinoplasty. Especially, I will invite Professor Tingchen Lu to give the professor a very warm introduction. So, please, Professor Tingchen, thank you.
Okay. So, Professor Narayana currently is the head of the department of the Charles Pinto Center, the Adewale Institute of Cleft Lip and Palate, Julie B. Mission Medical College and Research Institute in India. He's also the project director of Smile Chang, India since 2007. And Professor Narayana has been dedicated to the cleft care. He has the patient for the cleft nose and specialized in the correction of the cleft lip nose deformity. And I personally has listened to Professor Narayana's talk in India this year, which was very impressive. So today we are happy to invite Professor Narayana to give a talk about the unilateral cleft lip rhinoplasty. So let's welcome Professor Narayana.
Hi, good morning, good evening, good night to everyone. Thanks, Ting, for that lovely introduction. And yes, it's been my fortune to have been associated with you the last couple of years, and I deem it an honor to be able to present a talk on a topic which has been a passion for me in this webinar. In general, cleft rhinoplasties are considered to be among the more difficult rhinoplasties, requiring great finesse and judgment and attention to detail. Almost all that I have been doing in these patients have been procedures done earlier by my mentor, Dr. H.S. Aidenwala. All that I have done is to cobble together those maneuvers that have worked in the long run. There are many challenges in the management of the unilateral cleft lip nose at all periods. In the baby at the time of the primary lip repair, in the intermediate age group, notably the preschool ages, and in adolescence or adulthood. In the case of unilateral clefts, the cleft side hemicolumella is shorter, the ala is depressed and grooved, there's an alar flare with a widened nostril, the anterior septum is deviated to the non-cleft side, and the cleft ala base is riding high in view of the associated bony deformities. We follow the Millard rotation advancement procedure in all unilateral cleft lips, and we usually operate around 6 months of age. The hemicolumella shortening is adequately tackled by the use of the C-flap for lengthening, as advocated by Millard. It has been mentioned by some that such lengthening effect is a myth. However, we beg to differ. Here is an example of a child who has only had a cleft lip repair. The cleft side ala is depressed, grooved, and flat. During primary rhinoplasty, we perform an extensive closed alar cartilage dissection in the plane between the alar cartilage and the skin. This has helped in eliminating the alar groove. With this form of dissection, we've been able to achieve good results with regard to the alar overall. The septum, this is a patient who has had such a repair after 6.5 years. The septum in a unilateral cleft is deviated to the non-cleft side anteriorly. In primary unilateral rhinoplasties, we always perform an aggressive septal repositioning in all complete clefts. This protocol was established in the 70s by Dr. Edenwala. We separate the septal cartilage from perichondrium on both sides, score the cartilage on the non-cleft side, and excise a sliver of cartilage from its inferior border. Previously, we also shortened the cartilage anteriorly. However, we now refrain from such an excision as it weakens the anterior septum. We do not encroach onto the bony septum. Then we fix the septum in the midline. Earlier, we used to suture it to the newly formed nasal floor as shown here. However, this caused a deviation to the septum towards the cleft side in some patients, and now we fix the septum to the midline mucoperiosteum. Until recently, septal correction was criticized as being detrimental to the growth of the nose. However, long-term studies by Ander, Schmahel, and our own experience has shown that early septal correction is safe and actually produces much better noses functionally and aesthetically. When we did an extensive literature research, the only study that we found against septal intervention in the infant was a paper by Sarnat, and that was in rabbits. Here's a patient who underwent primary septoplasty at our center. The bony platform is depressed on the cleft side due to antero-posterior disparity between the medial and lateral bony shelves. This can be corrected to some extent by good nasoalveolar molding. When it persists, it can lead to a high-riding nostril on the cleft side. We use the Jackson uneven Z to minimize this effect. The nostril web is a challenge, and one of the options is to perform the Z-plasty, which was advocated by Charles Pinto, who was the teacher of Dr. Edenwala, and this is shown here diagrammatically. However, the one difficulty that can arise with this is that damage to the cartilage, which is just underlying the vestibular lining, can occur unless one is extremely meticulous in the dissection. I, for one, have almost given up doing this Pinto Z because I found that in many of my patients, I had damaged the cartilage in childhood. So now I rely more on modified Mecum sutures, which are sort of slightly different from that advocated by Nordhoff. And here the stitch comes from inside the vestibule and is tied there itself. But then it's introduced from the outside through one of the 23 gauge needles. These do give you a reasonable correction of the web on the table. However, in the long term, I have not yet been satisfied with the type of results on the web that we get from these. With all these procedures and interventions in the primary lip, we are able to get good results in many patients. However, we often see a soft triangle droop. If this is significant, we now offer to do an open rhinoplasty at around 5.5 to 6 years of age, because this brings the nose to the attention of peers at school, and immediately they become the subjects of ridicule and mockery. As I always say, children are angels only to their own parents. When they see another child with a blemish, immediately they call them names. Already, these children do not have a very high morale because of their deformities and need for multiple surgeries. So, this is a patient who has had unilateral cleft lip repair around the usual 6 months age, and at around 5.5, we have done the cleft rhinoplasty. The query is whether one should let these children suffer with these obvious nasal deformities until the time their facial growth is complete, that is around 15 to 18 years. Or should we offer them a simple corrective surgery at an intermediate age to produce a result like this and help them merge better with society with less of peer ridicule? Our answer to this query is a resounding yes in favor of performing preschool intervention on the nose. On the other hand, what would happen if we were to leave them as they are? We shall illustrate this with two examples. This patient had her primary unilateral cleft lip repaired with our protocol of primary septoplasty and closed alar cartilage dissection at our center. She was not brought to us by her parents until she was 12 years old, and she presented in this manner. However, here is another girl whose cleft lip dimensions were at least as bad as that of the previous girl. However, she attended regular follow-up and we performed a preschool rhinoplasty for the soft triangle blemish that she had. And this is her in her teens. Apart from the structural need, there's also a psychological reason to try to improve the lip and nose aesthetics as much as possible in these children. In a study of 26 children, ages 6 to 16, Demis and others found that non-syndromic cleft lip and palate children were at a risk of developing psychopathological conditions, especially depression, and that the severity of the dentofacial deformities was significantly associated with global function. Here is a boy who had primary cleft lip repair elsewhere. When he first presented at our clinic, he was very aggressive and mentioned that he had no friends. He was repeatedly pulled up by his teachers for aggressive behavior towards other students. All that changed when he had his lip and nose correction as per our protocol. As the blemishes are noticeable but mild in many cases, one is tempted to offer simple solutions. For example, at our center, we used to perform Kilner's crescentic excision for these mild deformities. In other patients, we used a Tajima reverse U incision on the cleft side alar rim and inserted a conchal cartilage on the alar graft. These procedures seem to produce good results at first. However, as you can see, within weeks or months, there was invariably a relapse, and we had to resort to secondary correction later. Hence, we gave up this and other such attempts and instead went ahead with a formal open rhinoplasty with sutural fixation technique that we have developed at our center in patients with a significant blemish. We do not do any small procedures anymore. We have found that the Tajima reverse U incision on the cleft side is the best to obtain alar rim symmetry. However, this is a tricky incision to master and often leads to an alar notch even in experienced hands. Thus, we have revised our protocol, and in patients with moderate alar rim height disparity, we use a Tajima reverse U on the cleft side and an infracartilaginous incision on the non-cleft side. In patients with a very slight height disparity and in those with gross disparity, we resort to bilateral infracartilaginous incisions. In all patients, we use a V at the base of the columella that is connected along the sides of the columella to the alar incisions. Initially, we used an unequal V as described by Bardak, but gave this up as in our hand, they produced unnaturally long columellas. An incision at the base of the columella has been frowned upon. There are two scars, a transverse scar at the base of the columella and a midline midline lip scar. It was illustrated to us by Ian Jackson that these incisions heal without scarring, and we have found this to be true. Here is an example. We boldly advocate the V incision to everyone. We then proceed with the dissection inferiorly along the sides of the columella. The medial crura are immediately beneath the incision and their position can be predicted accurately. Gentle dissection allows the identification of the medial crura and the entire columella skin envelope is raised with an adequate soft tissue cushion for vascularity. The dissection then proceeds along the curve of the columella ala junction onto the lateral crust using converse tip scissors. The ala dissection proceeds in a subperichondrial plane along the lateral crura all the way laterally, almost down to the alar base. Once the dissection is complete, we can identify the lower and upper lateral cartilages on both sides and the septum in the middle. Invariably, the lower lateral cartilage is inferiorly placed on the cleft side as compared to its counterpart on the non-cleft side. Next, we raise the cleft side lower lateral to the level of its counterpart on the non-cleft side by a sutural technique. This is the key Eden-Walla suture, and as shown here diagrammatically, it passes from the non-cleft side upper lateral through the septum onto the cleft side lower lateral upper margin, going back as a mattress again through the upper margin of the lower lateral on the cleft side, through the septum onto the non-cleft side upper lateral. Show this then this short video. Here is a patient. You can see that the cleft side lower lateral is placed lower than its non-cleft side counterpart. The stitch starts from the upper lateral on the non-cleft side through the septum. This is a 4-row echelon stitch and taking a bite on the upper border of the lower lateral, the cephalic border. And then it returns as a mattress, upper border of the lower lateral on the cleft side, returning for stability through the septum. This septal anchoring is what gives it its long-term stability, and onto the non-cleft side upper lateral. Just this one stitch alone, as you see, and when you redrape the skin, nothing else, no other stitches, you can see the dramatic effect of this stitch. So this is the key stitch for us. And often, as shown, just this one suture alone produces a dramatic effect, and this has been demonstrated in many workshops by us. We strengthen the columella by buried intermedial crural sutures. These should be placed, as shown here, between the medial edges of the crura and not the lateral edges. Originally, we were taking the stitches between the lateral edges, leading to unnatural looking columella. We rectified our technique watching Miss Cohen at a workshop in Chennai. Earlier, we were unaware of the proper method to obtain a natural narrow nasal tip in these patients. We learned from Professor Gubish at the Marian Hospital, Stuttgart, the technique of effective tip narrowing using transdermal interdermal sutures as shown. On both sides, transdermal sutures are taken, and then the interdermal suture brings the domes together to give a narrow tip. This again we shall show through with this short video. You can see the transdermal being taken on one side, returns as a mattress. Again is 4-row echelon. And it has been similar stitches taken on the other side. And the domes are brought together by an interdermal stitch. In fact, we now use more than one interdermal stitch as necessary. And once you actually see the patient and get your stitches, you realize that sometimes you need multiple interdermal stitches. There is no limit to the number. The ultimate result is what matters. So with this approach, we have been able to obtain good and sustained long-term results. And you can see the aesthetics, including the tip aesthetics that we have been able to obtain. And these are long-term results. This is another patient who is at the intermediate rhinoplasty. Soft triangle droop that you can see on the pre-op picture. And this is her post-op. This is 12 years after such preschool or intermediate rhinoplasty. All these patients have only had the exposure and dissection of the cartilages, the sutural technique fixation that I just mentioned to you. There have been no onlay ala cartilage graft or any other, except maybe where necessary, we would use some graft for the septum, but not in the intermediate age group. Usually, we don't need any other grafts in these children. This is a 15-year follow-up. Now, in patients who present with septal deviation after the growth is complete, we perform a septal repositioning along with open rhinoplasty. However, in the intermediate age group, we do not perform any septal work usually. This is because in our own patients, we have already done primary septal work. And even if a patient were to come from another center, if there is significant septal deviation where bony septal correction is also going to be necessary, we cannot do the bony septal correction at this intermediate age group. So we would wait for them to complete their growth before doing a definitive septoplasty. But if there is significant obstruction in intermediate age group, we do, in some very limited patients, we do a limited anterior septal correction, but that is a very, very, very small minority. So in patients who come to us in adolescent or adult age group, we do need to see what is wrong with them, and we have to do the appropriate correction. Very often, they need some septal work, especially if they've not had any septal work in the primary stage. Osteotomies are very rarely needed. Augmentation may be needed. And we do use sutural fixation of the cartilages like we do in the intermediate age group. Other problems like the tip, the alar, groove, flare, etc. need to be corrected. And the procedure is somewhat similar to what we do in the preschool age group. Now, when we have to do a septal correction in these patients, we resort to the dorsal approach. This we learned from Stuttgart. Previously, we were using other approaches, but once we learned this, we have been most happy with this, and this is the one we strongly recommend everyone to adopt. Because this is easily mastered, and what is more, one is able to dissect the septum from the perichondrial attachments on both sides without breaching the latter, even in the most convoluted of septal deviations. To get to the correct subperichondrial plane, we use a combination of sharp dissection using a scalpel and dissection with a plastic instrument. She'll show this again with a video. You need to separate the septum from its attachment to the upper lateral. And there we have approached that, and we have got onto the plane on one side. We use, as I said, sharp dissection with a scalpel, and we use this plastic instrument, which is originally a dental instrument, but which has been brought into the use for clefts by Dr. Edenwala, used it extensively in palate repair. But I find it really useful because it's flat, but at the same time, the tip is sharp enough to get into that plane. You see that it's a blunt dissection, but it's almost like a sharp dissection. And we then go down, separate the septum from the bony attachment. Once it's completely separated on both sides, we harvest a cartilage graft. In this case, you can see that the inferior part of the cartilage is actually bent almost horizontally. That needs to come off because that's not going to be stable and we cannot replace it. That once the septum is replaced in the midline, that's going to buckle. So that part anteriorly, lower part is excised, which has been done here. And then a cartilage graft is harvested, leaving behind a good dorsal and anterior support. That's the anterior support that is being left. And then we go on to the dorsum. Now, this is a swivel saw, a Bellinger's swivel saw that is an ENT instrument usually, but it's very handy to get in, especially at the back where access is difficult to get the graft with a scalpel. We take this graft. Then once we take the graft, we do harvest a cartilage graft from that. And very often we replace one graft there for the anterior septal support. A septal stability is very important for the long-term result of our cleft rhinoplasties. And we have realized this, and hence we do use anterior septal strut grafts. This can be used as extension grafts where when a tip projection is also needed. There is a weak internal valve as evidenced by a positive Cottle's test. Preoperatively, we use a spreader graft, and this is used on one or both sides as necessary. Here from the same septal cartilage, we are harvesting 2 spreader grafts, and these are placed on either side and suture. As already mentioned, we use septal cartilage grafts to reinforce the anterior septum and also as spreader grafts. We also use the grafts to strengthen the columella and alar rim grafts when necessary. In addition, we dice the grafts and use them for the dorsum and the supratip areas. We used to favor strips of graft for augmentation initially, but I've changed over to dice grafts after watching Dr. Philip Chen, Professor Gubish use this. The dice graft produce a much more natural appearance and can also be molded post-operatively for some time. We avoid onlay-alar cartilage grafts as far as possible. None of the patients whose results we have shown has any onlay-alar cartilage graft. This was not always the case. Till the early 2000s, we used to rely a lot on alar onlay cartilage grafts from the septum or concha. That was before we began using the sutural technique. While the appearance was satisfactory early on, we were repeatedly dejected on seeing the long-term results. The fate of the onlay-alar cartilage grafts and the need to avoid them was explained to us by Coat Cutting when he addressed the Smile Train Surgeons Conference at Mumbai in India in 2004. Here's a patient who had a dorsal hump and a cleft lip nasal deformity. She was operated on at our center by a visiting rhinoplasty expert who corrected the hump with an osteotomy but used just an onlay conchal cartilage graft for the alar. The patient was extremely satisfied with the dorsal correction. However, she soon came back within months and told us that it was as if nothing had been done for the ala. You can see it for yourself. And then she got corrected. Osteotomies are only rarely necessary in cleft lip nose patients. That has been our experience, and when we discuss it with other people who are doing a lot of cleft lip noses, we find that it's a similar experience with most. But when necessary, we use the percutaneous approach. We use lateral, transverse, and medial osteotomies. As I said, these are not often needed in cleft rhinoplasties. Now, with this sort of wholesome approach in adult patients, adolescent patients, we have one thing in common with all these patients. They've all had the sutural fixation technique, and none of them has had a alar onlay cartilage graft. This is a 1-year follow-up after sutural fixation. She had a wide nostril base, which was an attempt was made to narrow it using a rhomboid excision, and this is her after 1 year. This is 3 years after just merely sutural fixation of an adolescent patient. Sorry for the blurred image there. This is 3 years after our rhinoplasty. This patient presented to us after primary repair at another center. The septum was deviated to the non-cleft side and bent upon itself. We had to do a septoplasty, septal cartilage anterior strut graft, dice graft for the dorsum, supratip, and tip areas. And this is him. This is 4 years after sutural fixation. She also needed a scar excision on the lip. Wherever necessary and possible, we try to combine the lip procedures with the nose to minimize the procedures that these patients require. This is her 4 years after surgery. This is 10 years after the rhinoplasty, and subsequently, before this, she has also undergone a Lefort 1 osteotomy. She also had a lip scar excision, and this is her. Now, this is a patient who underwent one rhinoplasty elsewhere apart from his primary repair. And he came to us with quite deformed nose, and the medial crura were all deformed, and we had to reconstruct them. We did the open anterior rhinoplasty, bilateral infracartilaginous incisions, septoplasty. We used a spreader graft on the left side. We used dice graft for the dorsum and the supratip area, columella strut, and left alar rim grafts. Of course, we did the sutural fixations that I mentioned earlier. After reconstructing the medial crura bilaterally, he also had synecdoche on the left nostril, which were released. This is 2 years after the revision. The bony platform has been a problem area for us. When there is a gross piriform area depression, correction of the nasal deformity does not provide a satisfactory result. Augmentation of the bony platform is necessary, and hence we defer the rhinoplasty until after alveolar bone graft at least, at which time enough bone is used to elevate the piriform area also. We have tried other methods like using a Turkish delight graft, which is Surgicel, which is used to wrap up the diced cartilage, and we have used hydroxyapatite. Some of these have given reasonable results, but overall the results are unpredictable. The nostril symmetry is elusive, and especially if one nostril is smaller. We have tried Z-plasty, V2Y advancement, etc. When volume expansion of the nostril is also necessary, it is even trickier. In some of these, we use nasal conformers pre-operatively to get some expansion, and then the results are better. When volume expansion is necessary, full thickness grafts have been advocated, but then the take is very unpredictable in these patients. High-riding nostrils are best prevented by good nasoalveolar molding with pre-surgical orthodontics. In primary repair, we try to avoid this, as already shown, using Jackson's unequal Z-plasty. This reduces the problem in most cases. Once it's established, correction is difficult. We have tried Z-plasty to bring the alar base down. A good cinch suture often works better. However, any attempt to bring the alar base down works at cross purposes with the alar lifting maneuvers that are necessary in every one of these patients. Thus, though there are several challenges in the management of the unilateral cleft lip patients, if tackled appropriately at the different stages, we can hope to get reasonable, acceptable results. However, perfection has been elusive, and this is something which we are struggling to try and achieve. I don't know whether I will ever achieve it in my lifetime, but we will keep trying. Thank you.
Thank you so much, Professor Narayanan, for the amazing lecture. And thank you for sharing with us your experience and your techniques. So today we are very fortunate to invite two panelists, Professor Takayuki Honda and Professor Ike Tamada. So at this time, I'd like to invite Professor Takayuki Honda for some comments. Professor Honda?
Okay. Good evening. Thank you very much for the lecture. I mostly agree for your protocol for the cleft rhinoplasty. I have two questions for you.
Sure.
The first one is about the cartilage graft. You
Yes.
mentioned mostly about the septal cartilage graft for the support for this septum.
Yes.
But
Yes.
if you have a chance to use a cartilage graft for the support, what is the indication for the use of the cartilage graft? Costal cartilage graft. Indication for the costal cartilage. The second one is the
Yes.
post-operative. The second question is the post-operative care. Do you have use a nostril retainer for the post-operative care? Thank you.
Thank you so much. Both excellent questions. We almost always are able to use only septal cartilage graft for our patients. Where the augmentation is required, especially the dorsum, and there is not enough septal cartilage, that's the only time we go to the costal cartilage. I can tell you that we do a fair number of these rhinoplasties, and in the last 4-5 years, probably I've not had to go to the costal cartilage. We have been able to manage with this. But where there is a gross augmentation that is required, certainly the costal cartilage is necessary and comes in handy. Regarding the post-operative, sorry, I missed that out completely. Post-operatively, at the moment, we don't use retainers. We have just started getting some retainers. Previously, it was very difficult to get conformers here in India. The imported ones were too expensive. Almost 99% of our patients are done free under Smile Train. They could not afford a conformer. But of late, we have started getting some good conformers. But these are for the younger age group. For the older, I've not yet got a good set, but there are some which are now available in the market in India, and we will be trying them out. At the moment, all that we do is put in the conventional paraffin gauze nasal packs immediate post-operatively, and we use septal stitches to reduce the septal hematoma, to reduce the space and avoid a septal hematoma. and we remove the nasal packs in about 5 days. That's only for compression for the hemostasis. It's not for any molding. And in some patients where I've had nostril asymmetry later on, what we have done, and in some patients, as I mentioned, where the volume is small, even pre-operatively, we send them to our orthodontist who fashions an acrylic conformer, custom based for the patient, and they use it pre-operatively for 6 months, sometimes even 1 year. And we use similar conformers post-operatively now, but very soon we should be able to get good silicon conformers here too. I think in these patients, it is necessary to use nasal stents, but all the results that you have seen have been ones which have not had any nasal stents post-op.
Okay, so if you need a nasal stent, you make custom made for the silicone.
At the moment, that's what we're doing. But
Okay,
we
thank you
will
very
soon
much.
get thank you.
Thank you.
Thank you, Professor Honda. Next, I'd like to invite Professor Ike Tamada for some comments.
Hi, good evening. I'm Ike Tamada. I'm a pediatric plastic surgeon in Tokyo, Japan. Thank you for your very informative lecture. It was very interesting. So, Professor Narayanan, I have also two questions to ask you. And the first one is regarding the soft triangle drooping. In my hands, it is quite useful to use Tajima incision and a little bit excision of the soft triangle skin at the timing of primary cleft repair. So, what is your recommendation to deal with the abundant skin at the soft triangle drooping? When and how?
Thank you. Thank you for that question. Yes, the soft triangle has been a bugbear all these years. It's like a signature. You get everything else right, but then the soft triangle repeatedly comes in a significant number of our patients. So we have still not evolved a way of trying to avoid it primarily. But what you mentioned about using Tajima primarily with excision of skin, I have tried using the Tajima primarily. We had Professor Philip Chen come to our center. So he demonstrated to us not only using the Tajima, but he also did his excessive correction, about 10% more than what is necessary. He did that, and we did try that. But unfortunately, in my hands, that alone did not work. Regarding the excision, again, here I agree with Professor Chen that I would like to avoid excising any of that skin in the primary age group, because these patients very often do require another rhinoplasty. And when they require an intermediate or adult rhinoplasty, when you need a lift of the ala, in which you require in many of these patients, then you do need some skin which can be raised to that level. And this skin which we have there that we would remove in the Tajima, in fact, there are people like Malikan group where they say that for the web, they excise the skin from the web. But there again, Professor Chen doesn't, and we also follow that we don't excise during the primary any of the web skin, because that comes in handy when you have to do a rhinoplasty later. You can elevate that, you can raise that skin if need be with a Potter's V2Y release, but otherwise also by good dissection, and we are able to raise and avoid a rim notch. What happens when we do the Tajima in an intermediate or the secondary rhinoplasties is we do have to excise a bit of the skin, but usually when you raise it, that Tajima inverse, so the inferior flap comes in more medially, and that's where the excision is. That's where we have to excise. But I have not dared to excise it in the primary. What are your long-term results with your primary excision in the Tajima in the primaries? Are you consistently able to avoid a soft triangle? If that is so, I can buy it.
Yeah,
I'm
yeah,
looking for something that will.
yeah. I agree with you. Because the major crura is very weak, so
Right.
it's sometimes difficult at the stage of primary repair. So your recommendation is to preserve the soft triangle skin.
I would do that, yes.
My second question is about the psychosocial problem.
Sorry?
Psychosocial problem.
Yes,
Psychosocial.
yes, yes,
Yeah,
yes.
yeah. Basically, I would like to avoid intermediate rhinoplasty, but I agree that if the nasal deformity is causing serious psychosocial problems, corrective rhinoplasty may be necessary in some cases. And do you have any specific criteria to accurately determine the indication for the rhinoplasty? For example, problems like Cleft Q or patient-reported outcome measures such as
Right.
Cleft Q.
No, we haven't had any, we have no formal mechanism like that. The situation in our center is slightly different from many other centers, even here in India. I'm coming from Kerala. It's a place where the literacy rate is very high, and also the expectations and complaints from our patients is very high. This has been very good for us, because if I tell a patient, come after 1 year, then they will come 1st December 2025. If that is not our clinic day, they'll come one day this day. That much compliance is there from them. At the same time, their expectations are very high. So if they have see the smallest blemish, they point it out to us and ask us for correction. And what we have found is, when we have a procedure which it doesn't take much time, and you saw the other patient, one patient who had not come for the intermediate rhinoplasty, and when she came for the around 12 or 13, the deformity had, with the soft triangle, it had added on other elements, and it became little more difficult to correct. And also unnecessarily, this girl has been going through school with a nose like that. So when we have a solution which is not very invasive, it's just basically a sutural fixation technique, and which gives consistently good results across all types of these patients. So we do, when we see a blemish and when their parents are concerned, we straight away do it. We don't wait. We don't do any other psychological assessment or anything like this. I know it's not the same situation everywhere, but I believe in this, and when I see the long-term results of many of these, I think for me that is a vindication of what we are doing.
Okay, I got it. Thank you again for your lecture. Thank you.
Thank you. Thank you so much.
Thank you, Professor Tamada, for your comments. Next, I'd like to invite Tinchen Liu, Professor Tinchen Liu.
Hi, Professor Narayana. I think that's an excellent result, because
Thank you.
I have some cases with very depressed lower lateral cartilage, and after I do the secondary nose, and I found it's quite often to drop again. But I found your case is quite stable, and even stable for more than 4 years. So I think that's quite amazing.
Thank you.
I think you mentioned about the suture fixation technique.
Yes, yes.
And also the septal cartilage graft technique.
Yes, yes.
You combine these two techniques together, like always, or some patient you just do the suture fixation and some patient you use the graft?
Thank you. Thanks a lot. In the intermediate age group, we almost never do the septum. Because, if it's our patient, we have already done the septum in the primary stage. And if it is a significant deviation, it may be associated with bony deviation as well. And that we should not be tampering with in this intermediate age. So very often, almost in most patients, we do not do the septum in the intermediate age. And in all, whether intermediate or adult or adolescent, we always do the sutural fixation technique. In an adult patient, when a septum is needing correction, then we do the septum plus the sutural fixation. What I strongly recommend to everybody who is listening to this or watching this is that this sutural fixation has given us very, very sustained long-term results. In fact, 15 years results also they are still holding good. So what I suggest is if you are not fully convinced with the sutural fixation, please add it on to whatever you're doing. You may be doing other cartilage, onlay cartilage, whatever you're doing, add the sutural fixation technique to that. What I believe is over a period of years, you may slowly come to rely more and more only on the sutures and not on the additional cartilages. And in any way, it will definitely not do harm. And like you said, when you add the cartilage, etc., when it droops down later, this suture, which the septal pass is what is very important, because the septum is stable. We are making the septum stable. And when this stitch, which stays for long, goes through the septum and the lower lateral to the upper lateral, that plus whatever else you're doing, that should give you some more sustained long-term results.
Okay. Thank you very much.
Thank you.
Thank you, Professor Liu. And last but not least, I'd like to invite Professor Low for some comments.
Hi, Dr. Narayanan.
Hi.
Thank you for
Hi.
your presentation. I
Thank you.
have some question and I listen to your answer. I saw
Sure.
some of your case with primary lip repair. The cleft side alar base is quite depressed. And
Yes.
after repair, you can create that the alar base, cleft side, non-cleft side at the same plane, same level, meaning that you can elevate the cleft side alar base.
Right.
How do you do that?
Right. I think, can I go back to the slides?
Yeah, please.
Yes, please. Give me 1 second. Sharing option. Please go ahead.
I'm not sharing, right?
No, not yet. Not right now.
Okay. 1 minute. Let me share.
Yes, we can see it now.
Okay, I'm just going back to the slide that Professor wanted. Yes. 2 ways that the bony asymmetry can be corrected. One, I think people, especially Taiwan, is the leader in that, the nasoalveolar molding. You do get a very good anterior posterior disparity correction with the NAM. But we don't get that, though we do have NAM, we still have that as a problem in many of our patients. Now, this is a soft tissue correction. This was Jackson in his book, in the plastic surgery in infancy and childhood. In that book, Ian Jackson has written the chapter on cleft lip in the second edition of the book. And there he mentions that on the cleft side, he does a transverse cut. And then the gap is filled in by an acute angle cut on the medial aspect. It's an unequal Z, unequal in the angles. And this is only a soft tissue correction. And as you very pertinently pointed out, the moment before we were doing this, we were getting routinely, very almost consistently, we were getting nostrils which were higher and the deformity was there. But after this, that improved. But I'm still not fully happy with our the depression, the piriform area depression that we have. That is still there in a significant number of our patients, especially those who had a gross alveolar disparity in the beginning. And the only way that that can be corrected is by augmentation with bone, which we try to do at the alveolar bone graft time, not just the alveolus, but even high up to the piriform area. The bone is stacked to give some augmentation there. We have tried other things there for filling, like Surgicel with wrapped, Surgicel wrapped diced cartilage graft, which is called the Turkish delight graft, and hydroxyapatite works in some patients, does not work in others. So that bony depression is still one bugbear for me. I have not been able to say that we have eliminated in every patient. And when that is there and it's significant, the entire result of the rhinoplasty also is not very satisfying.
Okay, thank you. Well, actually, although we do name, and I do not think that we can correct the so-called piriform discrepancy between the cleft and non-cleft side. I think this still has to be solved by the soft tissue reconstruction, because the bony base asymmetry still exists. So this is my experience. Okay, my second question is that in the adult case, if you see the cleft side alar base is very depressed, you mentioned that you use Surgicel wrap the dice cartilage for augmentation in the cleft side alar base. So whenever you see the alar base depression, in the secondary reconstruction, you do dice cartilage and Surgicel to augment the cleft side piriform. Is that right?
We do a few things. One, we had a very excellent demonstration by Dr. Philip Chen at our center, where there was one adult patient who had a significant depression like that. And what he did was he revised the lip entirely and went all the way to the piriform area and released all the adhesions there. And I was wondering why he's doing that for a depression, but believe me, the result was fantastic. And subsequently, when I see that significantly, I do go back and do a lot of release there. That is one. The other is we tried in many of these, not only is there a depression, the muscle, the whole alar base is higher also on that side. So we dissect the muscle and bring the muscles from the nose, we bring that all the way down to the midline by a cinch type of suturing to add some muscle bulk also there. In addition to this, we do put in the Surgicel. What we make a sac out of this. We make a pouch and fill it with the dice graft and use it there in that place. As I said, it's worked in some patients, not in others.
Oh, okay. Thank you very much.
Thank you so much.
Thank you much, Professor Low, for your comments. Now, I think
Thank you.
this time there is no questions from the audience. Is there any questions from the audience that someone would like to ask? Okay. If not, I think we'll end our webinar for today. And thank you, Professor Narayana once again for the oh wait, actually, someone asked, what is the material of suture for your fixations?
We use non-absorbable sutures, that is nylon, 4-0 nylon is what we use both in the intermediate age group and adult age. And some people have had apprehensions about using non-absorbable material in the nose. As I said, we have a good long experience, and fortunately, we've never had to go and remove one of these stitches, and they have not produced problems. They are not even visible out. If you bury the knots, they're not even visible from outside, and you can't even feel them. These are questions that some professors have asked me when we are using these stitches on the surface, but they are quite safe and they are have not produced any problems.
Okay, thank you, Professor Narayanan. So
Thank you.
we're very happy once again to have Professor Narayanan to join us today for this webinar. And thank you to our good friends, Professor Honda and Professor Tamada, to come and comment as panelists. And our next webinar will be 2 weeks later on December 15th, and it'll be Professor Michael Lipka from University of Kansas, and he will talk on the topic of prevention of Lafort 1 complications. So we'll see you all 2 weeks later. Now, at this time, I'd like to ask everyone to open up their cameras, and we'll take a group photo. All right, good to see everyone. Okay, so let me count to 3 and then I'll remember to smile. 1, 2, 3. Smile. All right. Okay. And thank you once again. So we'll see you 2 weeks later. Everyone, good night.
Thank you. Good night.
Thank you. Thank you very
Thank
much.
you.
Bye-bye.
Thank you. Thank you so much.
Thank you so much,
Thank you.
Professor, for your lecture today.
Thank you. It has been a pleasure. Thank you so much.
Good night.
Yeah, and in the
Good
future,
night.
we also love to invite you to come on as a panelist too, if it's possible.
I definitely like to attend, and I'll also pass it on to my colleagues also.
Thank
Thank
you.
you so
Thank you so
much.
much.
Thank you. Thank you.
Thank you.
Thank
Thanks a
you,
lot.
Professor Honda. Thank you, Professor EK.
Thank you.
See ya.
See you.